Hi everyone, welcome back to Doctor's Desk. Today's topic is one of the most important high heeled chapters in medicine. Sepsis and Septic Shock, straight from Harrison's 22nd edition of Internal Medicine, chapter 315. So, this is very ICU important session. If you can recognize and manage sepsis early, you can literally save lives. And I have made a concise PPT on it so you won't get confused. So let's dive into it. So let's clear the basics first. The definition of sepsis has changed over the years. In 1992, we had sepsis-1, and 2003 we had sepsis-2. Then 2016 we have sepsis-3. So currently we are using the sepsis-3 guidelines. So sepsis-1 was infection plus 2 SIRS, criteria of SIRS. It was very broad, and almost all sick patients were fitting into this definition. Then sepsis 2 expanded with including organ dysfunction. In sepsis 3, so it included life threatening organ dysfunction due to dysregulated host response to infection. And septic shock is subset with circulatory, cellular, metabolic abnormalities leads to higher mortality. So we talk numbers now. Globally, around 49 million people get sepsis every year, and about 11 million people die every year. That's one in every five deaths worldwide. In US alone, it's about 1.7 million cases, and 350,000 deaths happen annually. So mortality is around 10 to 20% in sepsis, whereas in septic shock, it's about 40%. So there is a huge healthcare burden cost around $16,000 to $38,000 per admission. So this isn't just a medical condition; it's a massive public health and financial problem. So where does this sepsis come from? In about 88% of the cases, it's community acquired, and around 12% is hospital acquired. Then the urinary tract is the one of the most number one source, followed by lungs, then intra-abdominal and skin and soft tissues. Then pathogens like in for example of gram positive, it's Staph aureus, then streptococcus species and enterococcus species. Then in gram negative, E. coli, Klebsiella, and Pseudomonas. Then resistant strains like MRSA, VRE, ESBL, carbapenem resistant GNB, then fungi like Candida, especially in hospital acquired. So whenever you suspect sepsis, always think what's the likely site and what's the local resistance pattern that guides you to empiric antibiotic choice. So who's most at risk is think of the extremities of the age, elderly and neonates. Add immunosuppressed like HIV, transplanted patients, cancer chemotherapy, and add comorbidities like diabetes, CKD, COPD, malignancy. These all are red flag patients. Uh, Poor prognosis markers are like high SOFA score, elevated lactate, advanced age, and multiple comorbidities, and recent hospitalizations, especially in a patient in ICU. These people need aggressive management. So here's where things get interesting. Sepsis is not the infection itself, but the body's messed up responses. In Harrison, they gave a big picture to explain the pathogen. I know it's a bit confusing to you, so I'll explain it in a simple way. So there is something called pathogen associated molecular pattern and damage associated patterns from injured tissues. These two trigger the innate immune activation. They activate cytokines, ROS, then nets, which causes endothelial injury. This leads to coagulation activation like TF pathway, fibrin deposition, and impaired fibrinolysis. This leads to endothelial dysfunction. There will be capillary leak, edema occurs, then there will be decrease of O2 delivery. Eventually, it leads to mitochondrial dysfunction, decrease in ATP, and finally, organ failure. It's a syndrome of immune and metabolic failure. So, clinical manifestation, clinically, sepsis can look simple at first, like non-specific symptoms like fever, tachycardia, tachypnea, altered mentation, and hypotension. Then, but what's the key is organ dysfunction. In CNS, confusion, encephalopathy, severe hypotension, cold peripheries. In lungs, hypoxemia and ARDS. In kidneys, oliguria and rising creatinine. And liver, you see increased bilirubin leading to jaundice and coagulopathy. So, and don't forget the mimics also, like pancreatitis, heart failure, pulmonary embolism. They can all look like sepsis. So that's why you always need to think critically and not just jump to antibiotics for every fever and tachycardia patients. So, how do we recognize sepsis? So, enter the SOFA score. It looks at six system like neuro, lungs, CVS, liver, kidney, and platelets. A jump of two or more points means sepsis, but SOFA needs labs, so we do bedside like qSOFA, which is a rapid assessment. Like we use respiratory rate, then blood pressure, then with mentation status. Management in sepsis is a race against time. Harrison's and Surviving Sepsis campaign both say hit it hard in the first hour. So that's why they created first hour bundle. So we have to measure lactate, then obtain blood cultures before antibiotics, then administer broad spectrum antibiotics within 1 hour, then rapid IV fluids around 30 ml per kg crystalloids, then vasopressors if mean arterial pressure is less than 65 mmHg. Other essentials like oxygenation or ventilation, then source control like surgery, drainage, or catheter removal should be done. So each hour delay in antibiotic increases the mortality. That this is why we call it as a golden hour of sepsis. So now antibiotics, one of the most exam tested and clinically critical areas. In Harrison, they gave a big tabular column on it. So this is what I'm going to explain about. If you want, you can take a screenshot of it. So in case of pulmonary, community acquired pneumonia or hospital acquired pneumonia or ventilator associated pneumonia is going to occur. So in that case, use broad spectrum like so in community acquired pneumonia, you should use beta lactam plus macrolide plus or minus fluoroquinolone. Whereas in hospital acquired pneumonia or ventilator associated pneumonia, we should use a broad spectrum like piperacillin, tazobactam, then cefepime, meropenem, then plus or minus vancomycin or linezolid. Other considerations like MRSA risk, add vancomycin or linezolid. Then pseudomonas risk, add anti-pseudomonal coverage like piperacillin, tazobactam, cefepime, carbapenem. Yeah. Then coming to CNS, usually they cause meningitis or ventriculitis. Vancomycin plus ceftriaxone or cefepime is the drug of choice, and other considerations like 50 years alcoholics, immunocompromised, add ampicillin for listeria species, and neurosurgical or trauma cases cover Acinetobacter. In skin and soft tissue, necrotizing fasciitis, Vanco plus piperacillin tazobactam or carbapenem is used. In non-purulent cellulitis, vancomycin plus cefazolin or clindamycin is used. Other consideration: urgent surgical inspection, debridement for necrotizing cases. In intra-abdominal cases like community onset, should give ceftriaxone plus metronidazole and carbapenem if ESBL suspected. Then healthcare associated broad coverage like piperacillin tazobactam and carbapenem is used. Another consideration is like a high prevalence ESBL use carbapenems, whereas in pseudomonas suspicion use cefepime, meropenem or piperacillin tazobactam. In genitourinary cases, we usually see pyelonephritis, where we should give ceftriaxone, TMP-SMX, which is trimethoprim sulfametazole, or fluoroquinolones is used. Other considerations: if fluoroquinolone resistance is there, more than 10%, avoid empirically giving fluoroquinolones. Then, in hospital or complicated cases, use IV agents. So other organ specific like sepsis doesn't stop at one organ, so it's a system wide assault. Like neuro complications like encephalopathy, whereas in cardiovascular, 1 in 4 get septic cardiomyopathy. Then respiratory, around 7% develops ARDS. Then in renal, two-thirds develop AKI. Then liver offshore cholestasis or transaminitis. And hematologically, 35% get DIC. So every system can fail, and you need to anticipate complications before they happen. So this is why ICU care is not just about fluids and antibiotics, it's about monitoring and supporting every single organ. So that's what I was telling about organ specific clinical findings and management. You can take a screenshot of it and go through it. In supportive management, now this is a real ICU fight. Start with fluids, crystalloids alone, no starches, 30 ml per kg within 3 years, but reassess constantly. Too much fluid kills as surely as too little. So next, vasopressors. Norepinephrine is your workhorse. Target MAP should be more than 65 pressure. If still low, add vasopressin or epinephrine. And then dopamine is usually not preferred because it can cause arrhythmias. So if still hypotensive, add steroids. Then corticosteroids, hydrocortisone 200 mg per day for refractory shock not responding to fluids plus vasopressors. Then organ support for kidneys, RRT, I mean renal replacement therapy for AKI, acidosis, hyperkalemia or overload conditions. Then in respiratory cases, low tidal volume, 6 ml per kg with the low plateau pressure and conservative fluids in cases of ARDS. In cardiac, consider dautomine if myocardial dysfunction or a low cardiac output is seen. Then in nutrition, early enteral nutrition within 48 hours if possible. Then avoid overfeeding. Then prophylactically, we should give a DVT prophylaxis like low molecular weight heparin. Then stress ulcers prophylaxis also should be given. So let's wrap it up. So sepsis is a dysregulated host response to infection leading to organ dysfunction. Septic shock is the severe form with circulatory and metabolic collapse. So globally, it causes 1 in 5 deaths And pathogenesis involve immune overdrive, endothelial damage, coagulation, chaos, and mitochondrial failure leading to organ dysfunction. So clinically, it looks like fever, tachycardia, hypotension, but the key is recognizing which organ is uh, dysfunctioned in early stages. Management is all about the first 1 hour bundle, which I said earlier. So fluids, vasopressors, antibiotics, and source control should be given. Then add supportive ICU care for kidneys, lungs, heart, nutrition, and prophylaxis should be administered. So every hour of delay increases mortality. So the first hour is the golden hour in sepsis. So early recognition, early action save lives. Thank you and do subscribe to Doctor's Desk.